everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to the channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Dr. Lindsay Carlton, and she's going to talk about her study, the application of mechanical diagnosis and therapy on hip osteoarthritis, a case report. Dr. Lindsay is a physical therapist and diplomat in MDT. I hope you enjoyed the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative company Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi Lindsay, welcome to PT Pro Talk. How are you today?
I'm well, how are you?
I'm doing well. I'm glad you're making this work. So let's go ahead. For the ones that haven't heard our previous episode, just tell us a little bit about your background and then you're going to jump right on the paper that we're going to discuss.
Absolutely. So my background's in athletic training, and then I went on to PT school from there, and then quickly went through the McKenzie Method and got my certification and diploma. And currently I'm working in a certified McKenzie clinic with 2 diplomats as well. Awesome.
So on the previous podcast, we discussed one article that you published, and now we're going to discuss another one that is the application of mechanical diagnosis and therapy on hip osteoarthritis, a case report. And the paper was published on the Physiotherapy Theory and Practice. So let's go ahead and tell us a little bit about the paper and the goals of the research. Just give us like a background.
Yeah, absolutely. So the goal of this was to look at a patient with hip pain, and we were hoping with a diagnosis of hip OA or osteoarthritis, which this patient did have, and almost treat it initially and assess it as you would with a traditional assessment, not necessarily through an MDT assessment. So we tried to help to generalize our assessment so that it could be picked up a little bit more by somebody who doesn't have a background in MDT. So we did use goniometric measurements. We looked at CPRs and special tests, all of which can be utilized within the MDT assessment, but we tried to be very, very strict with that, and hoping that we could broaden our scope to other providers.
Yeah, awesome. And I was looking at your introduction about the prevalence of hip osteoarthritis, so it's so common. I think it was 1 in 4 people will develop symptomatic hip osteoarthritis. So I think that's a very good topic to be discussed. And
even more will present with it in an asymptomatic population, which even muddies the water further.
Oh, yes. So we're going to talk about these exams that you have findings in people that are symptomatic and how much that can impact the care of the patients, right?
Mm-hmm. Another downfall with the hip assessments as well is a lot of the special tests aren't necessarily specific or reliable. They did try to create test clusters, but we show through the paper that those test clusters might not be as useful either.
Yeah, so that I think it was very interesting about this paper that I am excited to discuss a little bit about. So walk us through how was the clinical approach and what were the numbers that you look at it and how the assessment worked?
So we took active and passive range of motion of the patient's hip, and also any functional concordant signs she attained with squatting and step-ups. We'll go over those more specifically when we get to them. And then we also measured her hip range of motion more specifically with a goniometer, whereas in our previous studies, we would just use them in moderate and major losses. We also performed the Scour and Favors special tests. Those are also part of the CPR, the clinical prediction rule. So we also included that. And we use the NPRS, the pain rating scale, the Western Ontario McMaster Osteoarthritis Index, or the WOMAC, and also the hip fear avoidance behavior questionnaire. Let's see. So the patient, she was 71 years old. Her pain was intermittent just in the lateral aspect of her hip. And she also had occasional anterior groin pain and sometimes some thigh pain as well. She had received a medical diagnosis of hip osteoarthritis that was confirmed by X-ray from her general practitioner and was ultimately referred to an orthopedic surgeon. The surgeon told her to go to PT 2 times a week for 6 weeks, but already told her before she had left the office that if the PT wasn't successful, she would be a candidate for a hip replacement. She went to a traditional physical therapy clinic and did complete her 12 visits and was compliant with their exercises. It was mostly general hip strengthening and stretching and aerobic conditioning, no MDT or mechanical assessment or any directional preference exercises, so just general movement in all planes of motion. She felt that the sessions were helpful and did improve her pain and functional limitations a little bit. But she did live independently with her husband in a second-story house, so she had to walk consistently up to the 2nd floor. And she had tenants that lived in the 1st floor, so it wasn't even an option for her to change her home setup. So she was still having difficulty negotiating her house, and at the suggestion of a friend who had been a previous patient at our clinic, suggested that she at least get a mechanical assessment through the MDT method before she pursued surgery. So she had these symptoms over the last 2 years prior to coming to the clinic and even prior to her previous therapies. But ultimately in the last couple of months prior to attending, she felt like they were getting a little bit worse. And she felt like her function was limited by 70%. She didn't use any assistive devices, but she did have a painful limp with ambulation, and she was limited with stairs, bending, and lifting. And she had scored herself a 53 on the WOMAC, which was severe functional limitation. Otherwise, she was relatively healthy. She wasn't using any pain medications or any medications at all, and had no other comorbidities or previous medical histories. There was quite a bit of loss of range of motion with flexion, extension, and internal rotation, and strength was limited throughout, but mostly because of pain. And her Faber and Scour tests were positive and provoked her specific symptoms that she had complained of. So we were using those as concordant symptoms and signs. And she fit the CPR, or the clinical prediction rule, for hip OA, because she presented with 4 of the 5 predictor variables, indicating a 91% probability of having symptomatic hip osteoarthritis. The patient, however, did not qualify for either diagnostic test clusters that are recognized by the American College of Rheumatology for hip OA. So we found that to be quite interesting, that some clinical roles she did fit for the diagnosis and some she did not. So that variability is often a key indicator that something different might be at play. She also could not perform a sit to stand without the use of her hands. So that was a bit of a concordant sign for us as well. And we also used a step up. We had her stepping up onto a stool in the clinic. And she also had pain with active hip abduction. So we had a lot of different baselines to go through, and we didn't necessarily always go back and retest those every single time, but we definitely went through quite a few to look at our changes. We used a typical orthopedic screen advocated by Cook and Hegis in 2012 to make sure that there was no lumbar movement loss, because that would be how a traditional physical therapist would screen for that. And there was no loss of lumbar movement and no pain provoked with lumbar movements. So we felt confident. She was assessed by a diplomat. So the diplomat chose to move on to the hip exam. We did make a note that if we didn't find directional preference at the hip, we definitely needed to go back and do a more thorough assessment. And this was also published prior to our previous paper where we talked about directional preference in the extremity versus the spine, and also prior to the XPOS study. So we really had nothing aside from our own clinical recognition that this might be a hip, but we had no research to support that at the time, aside from just our previous experiences. And it's kind of what prompted us to do more research to solidify that a little bit more. So by moving on to the hip, we found, again, just anecdotally through our own treatment in the clinic, that commonly if there was pain or loss of movement with flexion and extension, and possibly a little bit of a loss of rotation, the patient likely presents and responds to hip extension, either with or without rotation. So just as you would with the lumbar spine, you would typically start only with sagittal plane movements. So we first looked at hip extension with the patient. We did this in a partially loaded position, and what we consider partially loaded in our clinic was having her kneel on a chair with her unaffected leg in front of the chair and lunging forward, keeping her chest upward to truly get hip extension. She did quite well with that, and she several of her concordants did improve. She had slightly less pain with walking. Scour and Faber were negative, so she was no longer positive with those after just 40 repetitions. So we went through 4 sets of the exercise. Active hip abduction no longer caused pain either. And she no longer fit the CPR for hip OA after just 40 repetitions of the hip extension, which was pretty shocking for her as well as us. So based on that positive response, we thought that she presented more as a classification of derangement of the hip and not as the moderate hip OA. So she was sent home with the loading strategy of partially loaded hip extension.
Okay, so that's pretty crazy. How
Yes.
can you change? How can you change something so quick with like a few repetitions? It's probably crazier for the patient to understand what's going on, and she already been told that if she doesn't get better, she's gonna need surgery and all of that. And then with something so apparently simple, you have such a big change. So I feel like sometimes it's really difficult for the patient to like grasp that, right? So
yes, she was already kind of like mentally going towards the surgery route, so to change that so drastically, her mindset was not ready for that, for sure.
Yeah, so I'm curious to see what happened after that.
Oh, it gets very interesting. So based on that, such a dramatic response on the first visit, we expected that to carry over pretty well on the second visit, but she came back 48 hours later saying she was only 25 to 30% better. So we kind of scratching our heads, and we're like, that really should have been a lot more. And so looking, did we prescribe possibly not the correct directional preference? Maybe she didn't do it, or maybe she wasn't doing it properly. So we went through our assessment again. We reset the baselines of our concordant symptoms. Everything was positive again. Everything was painful again. Everything in the CPR was there again too. So we had her show us how she did the exercise. It seemed proper. We went through it several times, again, about 30 to 40 repetitions with her, and everything abolished again, which was really good, but also really confusing as to why that's not sticking or carrying over from visit to visit. Often in the lumbar spine, again, if you see that happen, you think maybe it needs more force. So we tested that. We tried to do fully loaded hip extension, which we reference as having the patient kneel on the floor on a pad and lunge forward in the same manner as she was doing on the chair. Now, granted, everything was already negative in terms of her pain at this point. And by increasing the force, it did not cause any return of pain. So we felt like it was proper to send her home with an increase of force, since there was no irritating factor with that. By the end of the session, the step up, the active hip abduction, and her sit stand were all pain-free. She still had a little bit of pain with walking, but much less, and there was still a limp. She returned 3 days later and said she was 60% better. So we were a little more ecstatic about that. Walking and bending were much better, but she felt like she was weak on the stairs when she did the full flight at home. But she didn't have any pain with the step up. She just didn't feel sturdy when she did it. There was still a little bit of pain with walking, but less so than the previous visit. And we reassessed her functional outcome measures, and there was significant improvement with those. And she no longer fit the CPR for hip OA. So she entered the visit not fitting the criteria, which was a great carryover between visit 2 and 3. So that really confirmed that likely symptomatic hip OA was pretty much not on the table in our opinion. Her passive range of motion and her concordant signs were present again. So her scour or her pain at end range was present with flexion, extension, and internal rotation. So we reviewed her home exercises again. She was instructed to make sure she was reaching hip extension at end range. When we demonstrated and helped to guide her a little bit in the clinic, she admitted that she wasn't going that far at home. So it was just a little patient education that she needed to consistently reach end range with her directional preference.
Mm-hmm.
She returned to us 1 week later, reporting 70% improvement. Again, a little disappointing that it wasn't greater, but she had said that 2 days after her session, she was significantly worse, had pain with squatting, sleeping, walking, and she had never had pain with sleeping prior to her reporting. But she never thought to call the office to let us know that the exercise wasn't helping. She did continue with the hip extension, but it didn't do anything for her pain during that 2-day period. And then on the 3rd day when she woke, she went back to continuing with the exercise and started to get pain relief and then felt better progressively throughout the week. We never saw her during that 2-day period, so we're not really too sure exactly what happened, but it was our hypothesis that perhaps her directional preference had changed. Again, based on our previous experiences, we've seen that sometimes if you're, again, lateral with the spine, lateral with the hip, if you've exhausted hip extension, you've increased force and you're not having a positive response, sometimes internal or external rotation needs to be added. And again, we never were able to explore that. When she did come back on visit 4, she was better, and hip extension continued to improve all of her symptoms. So we never explored a lateral technique because it wasn't needed at that time. She returned on her 5th visit, which ended up being her discharge visit. She said she was 80% improved. Again, we were hoping for a little bit more, but she had said that she felt confident in her ability to self-manage with her current loading strategy of the hip extension. She didn't have any exacerbation as she had in the previous sessions. And she still felt a little weak on the stair, but when we tested her hip abduction strength, which wasn't previously a concordant, it was 5 out of 5. So there was no manual muscle test to indicate why she felt weak. It was just a sensation she had. And there was no buckling or giving way. It was just the way she perceived that. We told her the only movement that was, or the only test movement that still was a little positive when she came in on the 5th visit was her hip scour test. But after she performed her hip extension, that was abolished. So we just told her to continue with her loading strategy several times a day and to contact the office if there was any exacerbation. We discharged her at that.
Wow, I think it's interesting how many things happen in the middle of the way that can kind of like throw you off the path of what you're thinking if you're not very careful. Yes. And have some experience on like, well, on the 2nd visit already, when she came back, you could think like, well, something is wrong. That's not the right direction. And then when she had again the 2 days that you said that she felt a lot of pain, you can like second guess herself as like, what's wrong? Why she's not improving? Like, should I change the load and strategy? But you have to have everything really clear and make sure you're doing your baselines and checking your baselines and make sure that you're not missing anything, right?
Mm-hmm.
Yeah. Okay. And then after that, you had follow-up at 1 and 3 month follow-up, see how she was doing?
We did follow-ups at 1 month, 3 month, 6 months, and 12 months. So at 1 and 3 months, she was continuing to note slow progressive improvement. She was compliant with the exercise still. These were all by phone, by the way, so we never assessed any of her baselines. But she just reported she was still compliant 4 to 5 times a day with the hip extension. and noticed positive responses with it, so continued. At the 6-month phone follow-up, she reported being 95% better. So we were very excited to hear that. She didn't feel that there was a strength deficit or loss of motion. So she felt a little bit better on the stair. So that had improved in time. Her only complaint was sometimes she would get a little bit of pain if she bent all the way to the floor, which she did often caring for her properties, or if she went for prolonged walk, she would also have a little bit of discomfort. She always found that going back to the exercise was helpful, and she had actually been able to travel cross country by car. So again, prolonged sitting, and no exacerbation or problem with that. So she was quite pleased that she was able to enjoy her trip. And then the twist.
Cool.
At 1 year, we did a phone follow-up, and I nearly dropped the phone. Actually, I did drop the phone. She told me 3 days prior she had her hip replaced. No phone call to the clinic, no discussion of that. At 95% better, we didn't even think she'd be a risk for that. But the surgeon got to her and told her that she should have it done sooner rather than later. When inquired further, we were trying to figure out if there was pain or a setback or something to prompt her to think that she needed that. And she just said that her surgeon told her that, and she wanted to do it while she was younger so that she didn't have as many risks with surgery, but possibly didn't need the surgery at all. She did admit to not having any pain, or she felt no functional deficits prior to the surgery. The only thing that she was still concerned with that did make her also consider the surgery a little bit stronger was that she still had a limp when she walked, but she admitted to it not being painful. After the surgery, the limp still exists.
Oh my gosh, that drives me insane.
Yes. So luckily she had a perfect surgery. There was no complications. So she was lucky in that regard. We did follow up by phone with her a month after the surgery just to make sure that she didn't have any deficits from the surgery. And she said that she was fine. She had 2 weeks of home PT, no formal PT after that. And at her 1 month surgical follow-up, she was provided a sheet of random strengthening exercises for the hip and told to complete them on her own independently, which she said she did.
Okay. I think that's how strong is this pathical-anatomical model, and how strong is the influence of surgeons on the patients, because it's just insane for me how that happens a lot. Even when they are better, they're almost 100%, and they still feel like, well, there is in the image it shows this, and this, so it's not gonna be fixed until I go and have the surgery. So that's yes. After you prove like all the baselines, everything, you're like, what's going on? It's just the mindset and the power of the doctors and the images, and I don't know, it's just insane.
Yeah. I was really upset when I got the phone call, and I was like, now we can't even publish the paper. And both the Joes, the other diplomats at the clinic with me, were like, we have to publish this even more now. And I was like, you're right, we have to. But I was concerned after the surgery because aside from the x-ray, nothing indicated that she should have. She didn't fit any of the clinical prediction rules. She had no more positive special tests. She had no strength loss. There's no reason aside from the picture of her x-ray to indicate that she possibly might need surgery. And we all know that that can be asymptomatic, which was her case by the time her derangement was reduced.
So I think it's just so frustrating that us as therapists, we are so driven to have results and help our patients, and we see they're improving. We see the cause, for example, if it is a derangement that is quick to respond and she's been doing fine with like 1 year follow-up, and then to see her going back and having like the hip replacement, I just imagine how frustrating for you. And like that happens in our practices, not way more often than what it should. So what is in your opinion, like what can we do? What because we do our parts, but it still is on their decisions. If they go back to the doctor, the doctor says like, yeah, that's in the image, you you're still young, you should do this before you get too old, and then you're not gonna be as healthy to fix this. So I think it's something in the culture that's really hard to change.
Yeah, and it's unfortunate too. She had it young. She was 72 by the time she had it. There's a chance it won't last as long as she does. Some of them can go 10, 15, 20 years, but her goal of getting it replaced was so that she could walk more and climb more stairs and really use it more. So she was going to put more stress and strain on it. So the risk of possibly needing a repeat surgery much later in life exists when we didn't need the first one.
And then it's going to be a problem.
Yeah. Yes.
Yeah. So I just think it's very frustrating. I imagine you probably discussed a lot that between all of you. And did you come up with some brilliant solution for us?
No, unfortunately not. So the biggest tool we took from this was how important it was to educate the patient. A lot of our referral sources are previous patients referring their friends and family members. So when we're finished with them and they are discharged, we try to educate them about joint derangements or dysfunctions or just the MDT assessment overall, and even into the other category and how we can treat and identify what is going on with the patient and then how to tailor their treatment based on what classification we place the patient into. We have a lot of our previous patients that will call and say, I have this friend, they are scheduled for surgery or considering surgery. Do you think you can assess them? And what we always like to tell our patients and anybody that calls the office to ask us that is at least let us assess. Within 3 to 5 visits, we can determine if you have a mechanical problem, sometimes even less. We identified that on the very first day with this patient. She walked out the door knowing that she was a hip derangement and didn't have the symptomatic hip osteoarthritis. That did not change her outcome, but really, letting the patients know there is no harm in the assessment. Worst case, you still go and have the surgery because that's what your choice was and you felt like you had access to that, and in the United States you can get whatever you want. So she was able to do that. In some other countries going through the medical system, I don't think she would have ended up possibly on the surgical list because she didn't, or at least she'd be way low down behind a lot of other people that did have more functional deficits. So I think it's just the accessibility is almost too easy for a consumer who doesn't necessarily understand what's going on. And I feel she was taken advantage of by that.
Yeah. And a lot of things that should be easier to be accessible, they are not. And things
like physical therapy.
Yes. It's just crazy. It shouldn't be that easy to get such a big surgery. It's so common here. It shocked me coming from Brazil. We don't have this many like knee replacements, hip replacements. Here is so common. Like we don't, it's just too easy. And if you want to, you just go ahead and 1 week or 2 weeks, you got it. It's just crazy.
Yeah.
And go ahead.
We like to tell this story a lot. We had a patient who had his knee replaced. He was a previous patient of ours. We'd seen him for a lot of different various orthopedic complaints because he was an active tennis and golfer. So we saw him for a bunch of different random things throughout the years. And he was limping around one day, and Joe Sr. had seen him out, and he was like, I hurt my knee playing tennis. And he goes, oh, call the clinic. We'll take a look and see what's going on. We saw him on the schedule the next week, so we assumed we were doing an assessment, and he walked in on a walker because he had his knee replaced. So in a matter of a week's time, and all that happened was he stepped awkwardly on the tennis court going for a ball and twisted his knee. And they took a picture. They're like, oh, arthritis. He was a little older. And within a week's time, didn't even try physical therapy. So I don't even know how they got approval for that. But they just, because he had an altered gait from the knee replacement. And that actually took quite a while to resolve the back pain. It did resolve eventually, but he was not happy because he wasn't playing tennis.
That is insane. That is insane. Yeah. And now that you just talk about the limp, I thought about the limp of your patient. So what did she said about after the surgery still having the limp?
She didn't admit to that. She's a very active member in our community, and I know the family well, and I see them out and about. So visibly, she still has a limp, but she did not admit to having that when we discussed it. She said the surgery went fine, and she was very happy with the outcome. But visually, assessing her gait from afar, it was still the same limp.
Yeah, well, that's crazy. I guess we have to position ourselves and explain exactly what it is, because I feel like some ways the doctors use their power. We don't have a lot of power as physical therapists, but at least try to be clear and tell like our position and help these patients make their best decision. And if that's what they want, we can do anything. We can just help and try to show what are the conservative possibilities and options. So, yeah.
Mm-hmm.
Okay. Anything else that you want to add, Lindsay, before we finalize this podcast?
No, I think that was about it. Certainly not the outcome we were all hoping for, but I think still very applicable, unfortunately, to a lot of what we see. Yes,
true. Well, I appreciate your time and your patience with this podcast. It's been a little difficult, but we made it. We made it to the end. So I appreciate your time. And if people want to learn more about you, or contact you, ask you questions, or discuss any cases, how they can find you?
I'm pretty easily accessible by my email, which is just my name, Lindsay Carlton 15@gmail.com.
Okay, perfect. Thank you so much, Lindsay. And I really appreciate you coming here and sharing with us your experience and talking about your paper.
Thanks for having me.